My name is Fay Maxted, and I'd like to welcome everyone to today's webinar, Trauma-Informed Healthcare, Where Are We At? And thank you to everyone joining us. I'm Fay Maxted. I'm the Chief Executive of the Survivors Trust, which is a national umbrella agency for voluntary sector specialist rape and sexual abuse support services throughout the UK and Ireland. I'm also a member of the Victims and Survivors panel for the Independent Inquiry into Child Sexual Abuse. The Survivors Trust team is delighted to be working with the TAC Care team to help disseminate their findings and increase the conversation around how to implement trauma-informed care. I feel sure you'll gain a lot from today's presentations. Before we start, can we go to slide 2, please? I'd like to run quickly through some housekeeping. So please note that the webinar is being recorded and we'll be sharing it via email and online within the next 7 days. If you have any questions during the presentations, please use the Q&A box, and we've left time at the end of all the presentations, and we'll be answering as many questions as possible during that time. If possible, please state which speaker you'd like to address your question to. So all participants are muted with cameras off throughout the webinar. The bonus for that is that you can be eating ice cream while you watch. No one will be any the wiser. But on a more serious note, if at any point you feel as though you need a break, please do feel free to leave and then rejoin once you feel ready. Next slide, please. For any accessibility questions, please contact Kate via her email. And Kate, if you could put your email in the chat, that would be helpful. For the multitaskers amongst us, we'd really welcome you commenting on Twitter to get the conversation out to as many people as possible. And please use the hashtag #TACCare. Thank you. So there is currently so much interest in working in a trauma-informed way, particularly in healthcare settings. But what do we actually know about working in a trauma-informed way? And what does the evidence tell us? Today, we'll be hearing from members of the TAC Care research team who'll be sharing valuable insights from the TAC Care study and sharing how these findings can inform trauma-informed policy and practice moving forwards. Within today's session, we'll first be hearing from Natalia Lewis, who'll be presenting the findings from the TAC Care systematic reviews. This will be followed by Shoba Dawson, who will discuss the involvement of people with lived experience in the TAC Care study. Elizabeth Emsley will then share the findings from the review of UK policies. Our final speaker of the day will be Jo Williams, who will discuss how TAC Care findings can inform system-wide trauma-informed policy and practice. Following the presentations, there'll be a question and answer session, and please post your questions using the Q&A box as we go along. Okay, so now I'm delighted to introduce our first speaker, Dr. Natalia Lewis.
Good afternoon. Thank you for joining us today on the hottest day on the record. It is 31 in Bristol at the moment. My name is Natalia Lewis. I'm a researcher at University of Bristol. Before transitioning to a full-time research career, I worked as a general practitioner and neurologist. I'm a principal investigator on the TAC Care study, which stands for Trauma-Informed Approaches in Healthcare. We are presenting today on behalf of a multidisciplinary team supported by people with lived experience and healthcare professionals. From research, from clinical practice, and from people with lived experience, we all have learned 3 important lessons. Firstly, many patients and healthcare professionals have experienced trauma, and all healthcare professionals work with people affected by trauma. Secondly, if these experiences and impact are not recognized and realized, services can re-traumatize both patients and staff. Thirdly, although it is very important to educate individual healthcare professionals about trauma, their new practices can only sustain if they are supported at the organization and wider system levels. Over the last 20 years, the framework of trauma-informed approach has gained momentum as a new way of service provision which prevent re-traumatization in healthcare services and improves experiences and outcomes for all. Many UK policies and guidelines recommend implementing trauma-informed approach in healthcare organizations and wider systems. To understand if trauma-informed approaches in healthcare are effective, we conducted 3 systematic reviews. First, looked at primary care and community mental health care organizations. Second, reviewed evidence from other healthcare organizations. Third review looked at effectiveness of stand-alone training programs on trauma-informed care for healthcare professionals. We also reviewed UK policies and guidelines. When we started our first systematic review, we quickly realized that people use different terminology and interpretations of the framework of trauma-informed care. And despite different terminology, when we analyzed 8 most cited frameworks for trauma-informed approach, we realized that they all provide a high-level guidance on how to transform an organization in a trauma-informed way, rather than prescribe what people actually have to do. Like the British pop band Bananarama sang, it ain't what you do, it's the way that you do it, and that what gets results. Analysis of the most cited frameworks demonstrated they all in general aligned with the US Substance Abuse and Mental Health Service Administration framework for a trauma-informed approach, which starts from the assumption that every patient and member of staff have the potential of being exposed to trauma and being impacted by these experiences, and therefore by realizing and recognizing these experiences and their impact, we can respond in a trauma-informed manner, which will prevent re-traumatization, improved experiences and outcomes for both patients and staff. A trauma-informed transformation of the whole organization is guided by the principles of safety, trust, peer support, collaboration, empowerment, and cultural sensitivity. And these principles and assumptions should be implemented across the 10 implementation domains. When we found studies that evaluated a trauma-informed approach, we realized that although they all followed the same assumptions and principles, they developed bespoke, unique models of trauma-informed approach, which were carefully tailored to their organizational needs, abilities, and preferences. And despite this variability, all the models had in common the following domains: an allocated budget, a working group or a committee, which was guiding the transformation process with representatives from all staff groups, including leadership and people with lived experience, ongoing training and support for all staff, and redesigning and changes in physical environments and clinical practices. Despite extensive searches, we only identified 6 studies that evaluated trauma-informed approaches in primary care and community mental health care. Numbers in brackets indicate how many studies reported each outcome. The arrow shows the direction of effect. Opposite arrows indicate that different studies reported conflicting results for the same outcome. At the individual patient level, we found some evidence in support of increased self-confidence, safety, health management, quality of life, and pain. However, the evidence for mental health and substance abuse outcomes was conflicting. At the care team level, there was a consistent evidence for improvement in staff accepting attitudes, patient perceived support, confidence in care, and feeling in control of their treatment. At the organization level, there was some evidence that staff psychological readiness to provide trauma-informed services increased and the organizational culture changed. This was captured through staff feeling safe, supported, and valued by their organization. Patient satisfaction improved. However, the evidence for change in staff uptake of screening for trauma and self-care activities was conflicting. Our second systematic review found 11 studies from other healthcare organizations and identified some evidence for improved retention among patients and staff and mixed effect on perceived quality of service and staff accepting attitudes towards trauma-informed approach. There was some evidence that patients' perception of trust, safety, and empowerment increased, that there was a reduction in restraint and seclusion practices. In line with the first systematic review, the effect on mental health and substance misuse symptoms was mixed. Our third systematic review identified 23 studies which evaluated effectiveness of standalone training programs for healthcare professionals. Most of this study measured staff psychological readiness to provide trauma-informed care before and immediately after training, and reported mixed effect of knowledge, attitudes, and confidence, and improvement in self-reported skills. In contrast, very few studies measured professional behavior and practices. There was a limited evidence for a reduction in restrictive practices, for increase in inquiries about trauma and patient disclosure, for incorporation of information about trauma into consultation. However, the effect on patient-doctor communication and referrals to specialist services was mixed. To conclude, healthcare systematic reviews identified limited and conflicting evidence for the effectiveness of trauma-informed approaches in healthcare. However, this limited and conflicting evidence shows that if a trauma-informed approach is implemented at a whole organization level and tailored to the organizational needs, abilities, and preferences, it can produce some changes in some psychological, behavioral, and health outcomes. Standalone training programs produced mixed effect on professional psychological readiness, behavior, and practices with regard to provision of trauma-informed care. Thank you very much for your attention.
Good afternoon, everyone. My name is Shoba Dawson. I'm a researcher based at the Center for Academic Primary Care at the University of Bristol. I am a methodologist with interest and expertise in evidence synthesis and increasing ethnic diversity in research. Next slide, please. Thank you. So today I'm going to mainly talk about how we involved patients and other stakeholders in the systematic review process itself, So in line with SAMHSA's principles of TIA, that's a trauma-informed approach, we thought it was a good idea to involve not just people with lived experience of trauma and health services, but also people who are responsible for planning, funding, and delivering health services. So as a result of this, what we did was we set up two advisory groups, really. One with people with lived experiences. We had 8 people involved throughout the review. As we progressed to the latter part of the review, we did have some dropout, and we had like 4 people who stayed involved throughout all the way through to dissemination. And then the second advisory group consisted of healthcare professionals and service providers, funders, etc. Again, we tried to involve them throughout, but by the time we got to the end of the review, we had like 3 or 4 people who were actively involved in it. So we met with these 2 groups once every 6 months or so. We thought it was best to keep these 2 advisory groups separately, simply because we were concerned, and there were also concerns from the patients that, you know, at some point or the other, some of the healthcare professionals they may have come across to discuss their health conditions and problems. So that's why we thought it was best to keep the group separate. We also ensured that we paid people for their time to get involved in the study. So this was in line with the National Institute for Health and Care Research Center for Engagement and Dissemination payment guidance, really. So as a result of that, everyone was offered a payment of up to £25 an hour. Next slide, please. Thank you. So in terms of levels of involvement, we were very keen to involve people throughout the different stages of the systematic review itself, but we did offer them flexibility, so they had the opportunity to pick and choose the extent to which they wanted to be involved in. Obviously, everyone was quite new to the whole systematic review process itself. So to begin with, in the first session, we provided them with an informal in-house training on what a systematic review is, the different stages involved, and how we would like to involve them in the review process itself. So this included brainstorming research questions with them. So for example, they helped and supported us to also reframe the research questions for the first systematic review that Natalia presented the findings for. This was all at the protocol development stage. So leading up to the registration on Prospero, we did all this then. We also asked them to list outcomes that were meaningful and important to them. While patients listed the various outcomes, healthcare professionals identified the inconsistent use of terminology in the UK. So this included, for example, adverse childhood events, often confused with trauma-informed approaches, which were sometimes, again, confused with trauma-informed care practice, or even psychologically informed environments. Sometimes they were used as synonyms, other times they all meant like different things altogether. So in terms of involving them itself, so we involved them in the data extraction phase, interpretation of the study findings, and also in dissemination of the study findings. More information in terms of how we involve them in detail can be found in the preprint link, to which will be available later on in the slide. Next slide, please. And lastly, one of the things we did was we gathered reflections from patients in terms of their experience of being involved in our study itself. For those who are interested, when the slides are shared, if you were to click on this link, you'll be able to read more on that. Thank you so very much for listening to me.
Hi there, everyone. I'm Lizzie Emsley. I'm a GP academic trainee in Bristol. So I spend half my time doing research here at the Centre for Academic Primary Care in Bristol, and the other half of my time working in inner city practice in Bristol. And I'm here today to share our findings from the trauma-informed care policy review part of the study. So as we've sort of found in the systematic review side of the study, we noticed that while we need a bit more evidence for trauma-informed care, and we need to sort of make that stronger, we did see that in UK policies, there is significant support and endorsement for trauma-informed care, and it's also something that's being talked about in UK policies. So we're really keen to understand more about the UK policy landscape when it comes to trauma-informed care, and to understand that in greater detail. Next slide, please. So in order to do this, we first wanted to have a look at how are trauma-informed approaches represented, discussed, talked about in UK health policies. And in order to understand that, we did a document review. So what that means is we found around 50 documents from the UK talking about policy with regards to trauma-informed care or any sort of related terms, and we analysed those documents. Those documents came from around 2012 to 2021, and we see a particular clustering of documents from around 2018, and I think that's perhaps really testament to the hard work from the trauma-informed community, where we're seeing it gaining popularity. The documents come from a range of places, so from across the UK, from Scotland, Wales, Northern Ireland, and from England. It can also, some of the documents are very sort of high-level UK government documents, and others are more sort of regional, local focused, and some of them also have a very strong sort of voice from service users and also from those with lived experience of trauma. Moving on to sort of the second part of our study, and what we wanted to find out was sort of really explore the understanding of trauma-informed care amongst policymakers and health professionals. So to understand a bit more about how they perceive it and also how it's being implemented in UK healthcare. And in order to explore this understanding amongst those who write policy and who implement policy around trauma-informed care, we did some interviews. So we interviewed professionals involved in trauma-informed care, including in the writing and implementation of trauma-informed care policy. We interviewed 11 participants on Zoom, and these participants came from a range of backgrounds, including the NHS, local authorities, and third sector organisations. So we had these two areas that we were looking at: how it's being described, how it's being represented in policies, but then also how it's being understood and how it's being implemented in on the ground. And we brought those two areas together in an analysis to look at areas of patterns and trends and areas of agreement, areas of disagreement on trauma-informed care policy in the UK. Next slide, please. So what do we find? Firstly, this first question of how are trauma-informed approaches represented, how are they described, how are they talked about in UK health policies? And what we could see really strongly was that, particularly in high-level, perhaps UK government or parliamentary documents, we can see that, yes, trauma-informed care is being promoted, it is being endorsed, but when you look into things a little bit further, that we need a lot more detail, a lot more guidance. There was a shortage of those areas, and also there was a shortage in terms of information about resource allocation, how it's being funded. And so yes, promotion and support of these initiatives, but we needed a lot more detail in terms of those specifics about guidance, funding, resource allocation. Next slide, please. And then on to our question about how are trauma-informed approaches understood amongst those who work in trauma-informed care and those who are involved in policy around trauma-informed care. So firstly, there was some debate around trauma-informed care terminology. So I think Shoba's have just recently mentioned about trauma, sort of other related terms like adverse childhood experiences and psychologically informed environments. And there was debate about this in terms of where does trauma-informed care sit with that related terminology like, adverse childhood experiences or ACEs, psychologically informed environments, or simply good clinical practice. Where does it sit in relation to all of those terms? And in interviews, we could see that some people felt that it's a bit of an umbrella, that all these terms sit underneath the umbrella and it acknowledges what people have been through in the past. All those terms are just sort of, an acknowledgement of what someone's been through in the past. Others felt actually perhaps there's some differences here. Perhaps adverse childhood experiences or ACEs are more of a research academic term, whereas trauma-informed care is more of a sort of practical service level term. So some debate around the terminology. Where we saw quite a bit of agreement amongst the policy documents and in interviews was that trauma-informed care is an organisational approach which needs to be tailored to the specific organisation and, most importantly, to those service user needs. And that involves looking at your organisation and seeing where there might be gaps, what the service user needs are, and then tailoring the model or the framework to those needs. It's not a one-size-fits-all model. It's something that is very much dependent on the organisation and on those service user needs. As part of this understanding of trauma-informed care, there was also discussion around it being presented as a remedy or as a solution to a range of health service challenges. And that includes acknowledging the widespread prevalence of trauma and the impacts of that in the population. Also, trauma-informed care as a remedy to or a solution to achieving integrated care, and also as a remedy or a solution to perhaps the widespread collective trauma of the COVID-19 pandemic that we might all be experiencing. So it's perhaps being presented as a means of addressing a range of health service challenges. Next slide, please. Coming on to how it's being implemented. And when we spoke to informants and looked at policy documents, we can see quite a piecemeal implementation across the UK. So while in Scotland and to a degree in Wales, there is a clear published strategy on national trauma-informed care. In other parts of the country or parts of the UK, that wasn't always the case. And for example, in Scotland, we can see this really coordinated strategy, and it's really leading the way. In England, while we do see initiatives across England, it's much more patchy, and we have some hotspots where it's really happening, perhaps related to a really active local trauma-informed community. So overall, there's piecemeal implementation, and there's perhaps a range of reasons for this. And in interviews, we heard about the fact that in the Scottish Government, there's significant buy-in and support for trauma-informed care. So a range of reasons for why this might be happening. Now, in terms of implementation, there are also some factors which help implementation of trauma-informed care and some factors which make it more difficult. And those are within the organisation and beyond the organisation. So within the organisation, there was discussion in interviews about if there's sort of senior leadership involved, that can be helpful. And if they're supportive of trauma-informed care, that is helpful. Others spoke about really active grassroots, bottom-up implementation, which can also help and be useful. There was also discussion about sort of trauma-informed care champions in organisations, which can help to gain support for trauma-informed care. And there was discussion around allocation of time and resources, which can be difficult in terms of which can help if it's allocated, it can help the implementation, but if it's not available, then it can make it really hard to implement. Beyond the organisation, again, allocation of resources affects the implementation of trauma-informed care, but there are also perhaps political factors in the region which can make a difference, and also nationally. We notice as well this evidence policy gap. So if I describe that, it's the endorsement for trauma-informed care in policy, but the fact that we perhaps need more evaluation, we need more evidence around the effectiveness of trauma-informed care, and we could see that coming through in our review. And in terms of implementation, that's something really important to consider, because if we have really strong evaluation, strong evidence, that's really going to help in terms of implementation. And again, in interviews, we heard about how that's difficult. Evaluation can be really hard to do if you need the time, you need the resources, and that can be really challenging at times. Next slide, please. So what about the future of trauma-informed care in UK policy? Where do we go from here? And there's already really fantastic networks being established and sharing of good practice when it comes to trauma-informed care. And that's something that we hope can be really strengthened nationally and regionally to help coordinate and harmonise trauma-informed initiatives across the UK. In interviews, we heard about calls for sort of more central leadership within the UK government. And again, that can help in terms of coordination and support for and funding of trauma-informed initiatives. And as part of that, establishing a robust evidence base specific to the UK for trauma-informed care and its policy is really important. So we think that it will be important to support and fund evaluation of trauma-informed initiatives so that we can build a really strong UK evidence base for trauma-informed care. We can learn what works, we can learn what's good practice, what can be extended elsewhere, what can be shared across the UK. Thank you very much. Next slide, please. So thank you very much for listening, and thank you for all the support for the studies that we've mentioned today. We've had a range of funders, including the NIHR and some other organisations mentioned here. So thank you very much for listening.
Good afternoon. My name is Jo Williams. I'm a consultant in public health from Bristol City Council and a senior lecturer at the University of Bristol. I'm here in my capacity as one of the co-directors of the Adversity and Trauma HIT. And speaking on behalf of colleagues of the HIT, we really welcome the opportunity to be part of this webinar today and to support the dissemination of the findings of the TAP Care study work. In the local area across Bristol, North Somerset and South Gloucestershire, we've been using the 10 implementation domains already described to develop our system-wide approach to trauma-informed policy and practice. And over the next few minutes, I'm just going to outline some of these developments and just give a few illustrations of how the TAP Care study is so valuable in informing this work. So next slide, please. It's already been highlighted the importance of leadership in developing this system, particularly from the TAP Care policy review. And we're really fortunate in the local area that the Healthier Together executive of our new integrated care system has committed to both supporting and championing the development of trauma-informed work in the new system. In practice, that has included appointing a trauma champion at board level and a senior responsible officer, and ensuring that we have a group within the governance structure of their integrated care system to bring people together to work on this. So we have the trauma-informed oversight group with membership both from what was the clinical conditioning group, now the ICB, and partner organisations, so we can work together. Also, partners have come together to jointly fund a post to help coordinate the work. It's been highlighted in the policy review that's just been presented, how we don't have a single policy framework for England, and the need to adapt the system to the local context. So in the local area, we've agreed a set of principles for trauma-informed practice. They're very closely aligned to the ones you've already seen, with some local changes. And over time, you're gradually seeing trauma-informed work appear more and more in our corporate and our partnership policy and strategy documents. And we're in particular developing approaches to commissioning of services. Engagement and involvement is so essential to bring in a range of voices and perspectives to develop the system at all levels. And we've seen how patients and professional stakeholders have been involved throughout the stages of the TAP Care study, shaping the study at every stage. And this level of engagement and involvement is just exemplary. We can learn from these approaches in TAP Care as we continue to ensure that we have engagement and involvement in our locally developing system. And we've hugely benefited from the input of public members in our trauma-informed system oversight group, the insights of patients and service users, and also more recently staff, particularly from our qualities groups. Next slide, please. Now, whilst the focus of TAP Care is on healthcare, the study findings have highlighted the need for cross-sector collaboration and how that's part of the implementation frameworks. And this wide collaboration is essential to developing this work in our new integrated care system. Building cross-sector collaboration means we have a common language, a common approach, and that people using our services will have a common experience in different types of services. And we're really fortunate locally to have really good cross-sector collaboration, for example, between health and social care, with the police, with our schools, voluntary sector organisations, and our universities. And of course, today's webinar is demonstrating many of those collaborative links. One of the systematic reviews talked about training and workforce development and how there's still mixed evidence of effectiveness. And locally, we want to enable our staff to build their skills and confidence, but we realise we don't have all the answers yet about the best way to do that. Locally, we've developed a knowledge and skills framework, building on engagement with young people and adults. But in the light of the TAP Care findings, we'll continue to evaluate our approaches to training and look at ways to do this collaboratively cross-sector. And just a final comment on evaluation. There's so much learning from the TAP Care study, but it's also highlighted where there are still gaps in the evidence, and we've seen that in the systematic reviews and the sort of highlighting the evidence policy gap. As we develop the local system, we're really striving to learn from research evidence and to build in evaluation at every stage. And we're really fortunate to have the Bristol Health Partners, in place, and their support through the HITs to enable us in this work. So through the Adversity and Trauma HIT, we're working together to build bridges, to bring in research evidence and to develop our approach to evaluation. And this work of the HIT is very closely aligned to the work in the integrated care system. So just to finish, let me express my thanks to colleagues in the TAP Care study who've carried out such careful and thoughtful work. It can help us build on the evidence base as we develop our local trauma-informed policy and practice, and as we work together to continue to evaluate that work. Thank you.
Thank you, Jo. I'm going to now hand over to Claudia Williams, who's going to answer some of the questions that you've been posting throughout the session. She's going to facilitate this session. So any questions, please do put them in the Q&A box. And hopefully we'll get round to them in the time we have left.
Thanks so much, Faye. So we do have one question aimed at Natalia. Natalia, will you be able to provide the preprint or published articles for the systematic reviews?
Well, so at the final slide for today, you will see how you can stay connected with the TAP Care study. There will be a link to the study web page. The systematic review 1 paper is under review in health and social care in the community since December. So the preprint is available. You can access it from the web page of the study. Our policy review paper is under review at BMC Health Services Research, and I understand that Lizzie will upload preprint very soon. So if you follow the TAP Care study, we will be uploading publications and all academic outputs in due course.
Brilliant, thank you, Natalia. Another question from Anne Hain. Is there a sense that it is better and easier to deliver trauma-informed care across primary care before tackling acute care settings?
I could contribute a little bit here. I don't know if anyone else wants to chip in as well. I think having a look certainly at the policy review, we could see that the area actually most commonly referenced was mental health services. So perhaps it's difficult to say for sure in terms of where it's being implemented. Perhaps that's a particular area of focus amongst in services. But at the moment, I think it's not being clear that it's specifically easier to implement in one sector than others. I don't know if anyone else would contribute here.
I agree with Lizzie. I mean, it is a universal approach. It can be implemented in any healthcare organization. Our second systematic review found that if it was implemented with newly employed staff or like in a newly set service, it was easier to do than trying to change an existing service and established organization. This is one of the findings in systematic review too.
Could I just add a comment? I think this is one of the great opportunities now with integration across the system between primary care, our acute trusts and social care, that we can have common approaches and support one another in building these organisational approaches. So I hope that they're sort of not one first or the other, but we can work together.
Thank you all so much for your insights there. So the next question for the panel is, what sort of data capture would you recommend to be able to measure outcomes for patients?
If I may, I will respond to this question. So if you look at preprints and you will look at the studies which we included, you will see that every study used different measurement tools. So my feeling that because a trauma-informed approach must be tailored to the organizational needs, abilities, and preferences, the evaluation framework should be tailored to the organizational needs, abilities, and preferences. You should develop your evaluation framework with healthcare providers in the organization you are working with. But there are bespoke questionnaires, there are validated standardized questionnaires, there are qualitative methods of assessment. I didn't have time to say that we didn't find any evidence for cost effectiveness of trauma-informed approach in healthcare. There is a huge gap on that. So it is a developing field, but look at published examples. Maybe you can borrow and adopt to your particular context.
Brilliant, thank you, Natalia. So another question for the panel, perhaps for Shoba. How did you incorporate a trauma-informed approach to working with your advisory group of people with lived experience? To what do you attribute the dropout rate?
Thank you so very much. I must confess, we didn't really specifically adopt a trauma-informed approach when working with the advisory group as such, simply because we looked at everything from a more of a patient and public involvement perspective, and we carried on along those lines. However, one of the things we did do was, as we were recruiting people to take part in the study and help and support us from an advisory capacity, people had the opportunity to share their experiences to the extent that they were comfortable with. They could do the same at the very early on meeting as well. And post meetings, if anyone had any issues, qualms, etc., we were always available for a chat as well. In terms of dropout, it was mainly because of like other personal commitments, really. So this was something we did follow up with people where we could, and that was the main reason why they did drop out. And fortunately, nothing else to do with their situation or circumstance in that sense. Thank you.
Thank you, Shoba. So another question, does the guidance consider trauma-informed approaches or training for non-clinical staff, for example, receptionists?
When I listed the most common components which we found in all across included studies, I mentioned one component which we called ongoing training and support for all staff. And the idea of the whole organization or system approach is that all members of staff from all groups must be trained, because it is an organization system level approach, and all non-clinical staff should be trained alongside with clinical staff and management, etc. Yeah, of course, only for all staff.
Can I just bring a reflection from the local area that our knowledge and skills framework across Bristol, North Somerset and South Gloucestershire would apply to all staff, but with different components, perhaps depending on the role. So really that as a whole team in an organisation, everyone needs to be taking the same approach, but with their different roles needing different types of training.
Brilliant, thank you so much both. So a question for the panel. If Jodie was to develop an audit tool for their team within an NHS organisation to review how trauma-informed they were, what would your advice be?
I would advise to go to the existing frameworks and evaluation frameworks, and instead of inventing the wheel, just take the existing one and adapt it to your trust, needs, preferences, and abilities. There are several frameworks available, and we will share a link to at least 2 papers which summarize what examples, which tools and frameworks you can use. There are more research evidence frameworks and more kind of best clinical practice frameworks. I don't know if Angela Kennedy or her team is in the audience. They can share a link to their narrative approach, which is based on sharing best clinical examples. Yeah, so it's all in literature. You can take, adapt, and apply to your particular setting. We will share links to the studies.
Thanks so much, Natalia. So a question from MD. They would be interested in understanding what was incorporated in the competence framework identified in the BN SSG, and whether you have any key suggestions in building staff skills and confidence, especially across systems.
Yes, I can comment on that. It's probably best if we share the link to that document so that you can have a look at the detail yourself. It's currently actually hosted on the Keeping Bristol Safe partnership website, but it applies across the whole geography. So I can make sure that's shared. And I think it's important to sort of also describe that that the particular, I guess, focus will be slightly different for different staff groups. For example, at the moment, Avon and Somerset Police are doing a very significant multi-agency training programme, which has benefited many agencies, but has had different levels of training. So a sort of much briefer training on offer through to a sort of 9-day training for some senior leaders. So I think the best thing would be to have a look at that document and do come back if you've got any further questions.
Brilliant, thank you, Jo. So we have a comment and a question from Sally Easton. Natalia, while we are all hopefully becoming more trauma informed, there seems to be little about implementation. So regarding it's the way that you do it, are you able to comment on any papers or examples of successful practical implementation of trauma informed strategies?
Yeah, I mean, all our papers, studies, which we included in our systematic reviews, they were all successful implementations. They just produced different outcomes, but they all demonstrated that if you implement it at the whole organization level, you really can change, at least in some patients, in some members of staff. You can change their psychological readiness, you can change their behavior and practices, you can improve patient health outcomes. By the way, we didn't find a single study which would evaluate health of members of staff as a result of implementing a trauma-informed approach. So look at our preprint for a systematic review 1, and all the studies which we included are a perfect example of a successful implementation of a trauma-informed approach in the real world healthcare organizations.
Brilliant, thank you, Natalia. A question from Luke Turnbull. One of the worries from GPs in their area is about undertaking a trauma inquiry approach, in that they'll need to make lots of onward referrals to services that are really overstretched. So did any of your research find evidence to support or refute this?
So the evidence shows, and you saw, I think it was a systematic review too, that referrals to specialist support services, the evidence was conflicting. Some studies showed that it increased, some studies showed that it increased. I mean, implementing a trauma-informed approach means extra burden on staff. This is true, and you cannot load this extra burden without providing structural support and providing referral pathways and psychological support to staff. So that is why it looks like if you try to implement bits of pieces from a trauma-informed approach framework, like for example, a training, one-off training, which trains your staff to ask, identify, and refer, it does result in changes in awareness, but it doesn't result in changes in practices. So to achieve changes in practices and to sustain, you have to change the system, the organization, and wider systems. My feeling that it is not a quick fix, a trauma-informed approach. It is a long and painful process. This is my feeling from research evidence. I don't know, maybe people in the audience have different experience from best clinical practice, but this is what research shows. I came across one paper from America where they said that they started picking up improvement in outcomes and experiences after 2 years since they started implementing a system-wide approach.
Thank you, Natalia. Just very aware of time. We've got about 2 minutes left. So if any of your questions haven't been answered, we will do our best to get that information over to you via email. So Natalia, I'd like to finish with a final question. What are the next intended steps for the TAP Care project?
We just started planning a next step. We want to bring this evidence into practice. We want to work with 4 general practices in Bristol, North Somerset and South Gloucestershire area. Practices which are research active would like to implement a trauma-informed approach at the organization level. And we would like to collaborate with them to try and help them to adapt a generic framework, let's say, for example, the one developed in BNSSG, to their organizational needs, abilities, and preferences. So if you are a GP or anyone working in general practice in this area, please get in touch, use contact details on next slide, and we will be happy to work with you on implementing this approach. We will disseminate our findings further. We're working on a piece of animation. We will be producing policy briefings, infographics. So we will try to disseminate our findings to non-academic audiences. And we would really looking forward to work with policymakers to really help them to use our research findings in policy and practice.
So finally, thank you for taking the time to attend today on the hottest day that we've ever experienced in this country. Please do keep in touch, follow CAPC Bristol on Twitter or sign up to the Centre for Academic Primary Care newsletter using the link that's displayed on the screen. And you can also find more information about the TAP Care study on their website, which is bristol.ac.uk/tapcare-study. And next slide, please. So for anyone who's been affected by trauma or any of the discussions today would like information or support, we've included details of key organisations on this final slide for people to find help. Thank you very much for attending. Look after yourself in this heat, and thank you all. Goodbye.